And welcome everyone. This is our regular webinar series, and we try to profile at least one solution in each of our webinars, and also give you an update on what are some interesting things happening in the digital health space. So today we are going to have two speakers, and I'll talk a little bit about them. But just wanted to give you a quick update on what has been happening on the NCG front. The NCG EMR project, I think we're now up to 20 hospitals, so that's great progress. I think all of them are in different stages of implementation, but we do have 3 hospitals live now. Um, so that's great news. I think in addition to that, a lot of other interesting work. I had updated you guys on the telemedicine project that we were doing. So those 2 pilots are going to get started very shortly in January. So we'll update you next time in terms of what the progress is on both of those. We're also fairly close to curating the virtual tumor boards, at least for the pediatric hematology cases. That's where we are starting. So all of those recordings are being tagged with metadata so that they're easily searchable and can help with both the training process as well as for clinical decision making. So you should shortly hear about that. The Digital Health Foundation course is already live on the NCG Education portal. So for those of you who may not have had a chance to look at it, it's a self-paced learning program, more like a one-on-one course for anyone who wants to understand the basics of digital health. And in fact, today, one of those modules on emerging trends in oncology, we are going to profile. Dr. Bhavna is going to take us through that part. But please do visit when you get a chance, and encourage others to undergo that course as well. And lastly, I'll mention about the Digital Health Solutions Library, uh, which is also going to be available hopefully by January, which will have a list of curated solutions by NCG, where you will find the details of those solutions by categories, as well as the ability to get some references and information about each of those vendors. Uh, and then let me come to the topic for today, which is AI ML in oncology. Obviously, that seems to be the buzzword now these days everywhere. And we formed a small subcommittee of AI experts within NCG. They are external experts to guide us in terms of how do we even think about AI ML from an NCG perspective. So before we get to what should we do in terms of the use cases, we really want to understand what the foundational framework needs to be, both in terms of privacy, security, the ethical considerations. For companies who have interesting products but are yet to be tested, how do we provide some real data through NCG to them so that they can improve their products? And for hospitals who are interested to participate, how do we bring those two together? So a lot of work is happening in terms of just putting that framework together. I think once we have that framework ready, we'll open it up to a lot of product companies that want to pilot or do a POC with NCG hospitals. In parallel, we are also going to form a small subcommittee of NCG experts who can guide us on what use cases make the most sense for us to deploy AIML, so that we can have some real world examples of what is working versus just being in the lab. Uh, so we'll give you more updates again next time that we meet. Again, all these webinars are recorded. They are available on the NCG website. So once this webinar is complete, we'll edit that a little bit and put that up as well for those of you or your colleagues who have missed. With that, let me turn it over to Swapna, who will introduce our first speaker. Uh, Swapna, over to you.
Thank you, Nikesh. So good morning, everybody, and welcome to today's webinar. We look forward to having an engaging session today. So the first speaker today we have is Dr. Bhavna Sirohi. She is the Medical Director and Senior Medical Oncologist at BALCO Medical Center, Raipur. Dr. Sirohi is going to share her expertise on emerging trends in digital health for oncology. So over to you, Dr. Bhavna.
Hi, good morning, everyone. And thank you to National Cancer Grid and Quetta Foundation for actually working in this space and driving this, because I think this is one of the most important module for us in oncology, at least, in democratizing the care because we have so many different models. In India, different healthcare settings. So this is a little bit about me. Just to briefly tell you, I am a breast and GI medical oncologist, and I have spent a long time in London and have been working only with EMR since 1998. I was instrumental in setting up the medical oncology information system in Tata Hospital, where we worked with the in-house computer department to set up e-prescribing for chemotherapy in a very safe way, and how we integrate that with in UK we had the British National Formulary, but how we integrate with the Indian MIMS to make sure that, nowadays every week there is a new drug which is approved. So how do you make sure that you deliver safe care? By making sure that the drug interactions are looked at, because it's impossible with so many new drugs for you to remember everything. So you have to have a module which actually tells you that, okay, you're giving capecitabine, you can't give allopurinol. So it doesn't, the app should not let you prescribe that. And that's what I love about digital health in oncology. So that was my first experience, because it helps you deliver safe care to your patients. So I'll just talk a little bit about some mobile apps and AI and machine learning, and I would love for you to actually put it in the chat box. If you have any questions, the NCG team is here, Dr. Nikesh is here, his whole team is here, and they can respond to some, and I'll be able to respond to some. I think we're going to talk about how it significantly impacts cancer care, and I will give you some examples about that, and how we can apply that right from, I would say, prevention. There are a lot of data, algorithms, a lot of stuff people are talking about. I was listening to a conclave as to how the AI and machine learning can, help tell you what your genetic makeup is. Again, there are challenges to that we can talk about. And we're going to focus on AI and ML and how they are actually driving cancer care. So what do you think are the emerging trends in digital health for oncology? I would love for you, each of you who are listening in, to put your answers in the chat box, because I think when I finish, we can sit and discuss these as well, as to, something that we have missed or something that we should prioritize and we are not prioritizing. So I would love for you to put this in the chat box. So if you look at the mobile apps, you have quite a few. Like I said, it starts from prevention. The screening apps, you have nowadays, we had for COVID vaccination, we had the fantastic app which told you, when your vaccination was due. I have actually started that for Chhattisgarh in HPV vaccination, because yes, we are giving one dose for 9 to 20-year-old ladies as per WHO, but there are some girls who are getting the Indian vaccine. They need to get the second dose, they need to get the third dose. So it's important that they get the reminder and they know that, at 2 months, this is what you need, 6 months you need, this is for prevention. But there are screening apps as well, which should remind you that you're due a mammogram, you're due a pap smear, you're due do your stool occult blood. So these are tests which save lives, and we know that. And then you have, like I said, the genetic and risk assessment apps, and we can delve into it in detail. What I find the most exciting and which I adopt and I love is the symptom treatment and side effect tracking apps. And I'll tell you why. And of course, the survivorship applications are there. You have also these lot of apps like Mama, quite others for self-breast examination, the time of the month you should do it, how you should do it, and you put a tick there. So all of these are important. And also for us to progress in cancer, I think clinical trial matching, we lack that in India. I have a colleague, Dr. Amol Patel, who's actually started, he said, he'll put everything in each institute, and he's tried to make an effort in putting all the clinical trials, because nowadays care has become so personalized. If I have a patient with this exon 19 mutation and he's progressed through treatments, I would love to know that if there is a third line treatment or a second line treatment, because patients would be happy to travel within India. And we need to know which trials are running pan-India for each of these. Not all of us can do all the trials. So if we have a central registry, I think that would be fantastic. And this is how we would deliver best care for our patients. The mobile apps, if we look at the screening apps, we're just going to give you some examples for you to, look at and, see whether it works for you. But there are hundreds of others which are looking at these as well. And these are using AI-based technologies in using the smartphone sensors, your watch that you wear, or sometimes you have, so we have a poll right now. So which AI ML use case in healthcare do you believe has the greatest potential to transform patient care? So please do that, and maybe at the end of it or in the middle, we can show you. So I think I've already disclosed what I find is the most, but we would love to hear what you all feel as well. So we have about, I think, more than 60 of you. So we should have at least 76 of you. So I think we should have at least 76 responses. Okay, so we have these apps where the camera, you can look at how the mole. I normally tell patients, take a picture, store it, and then, every month you take a picture. And this is how we tell them, but the onus is on the patient actually to do that. Here, if there is an app which actually can tell you, can take a snapshot of these moles. Some of us have a lot of moles, and it's important to, scan this and, have a result at the end of it that, it has increased by 0.1 millimeter, or the redness has increased. So the AI-based algorithm does ensure high accuracy, but we'll discuss the challenges related to these as well down the line. For genetic and risk assessment, again, you have apps which are designed to interpret genetic data. But again, there are challenges related to ethics. But most of these apps, it's important that you look at the clinical validity and utility of these apps, and also the data privacy and security is very, very important, because this is very, very confidential data. But yes, if you have a strong family history, if you are a smoker, if you use that, there are various things one can put in the module to assess your risk for developing heart disease, for developing liver disease, or even cancer. So I think this app, Genome Map, categorizes findings into areas like, whether you have hereditary disease or you have traits. Like here, this would be very useful for our patients' population, because about 20% of the tribal population has a sickle cell trait. So it would be great to, track this and also look at pharmacogenomics and other genetic markers. ChemoWave and AIMS Upchar are two apps which do track symptoms. Like I said, the future in oncology, it's especially for patients on various, whether it's surgery, radiation, or chemo, is looking at how are patients behaving to these treatments, and what their complaints and what their adverse events are, whether they have symptoms. And these apps let you track that. So the PROMs and PREMs, the patient-reported outcome measures and experience measures, both of these are very important. And I've just put this slide to show you, a drug gets licensed or approved by FDA, EMEA, or whatever, DCGI, with a 1 month survival benefit. Or, the drug was approved with a 2-week survival benefit. But you have this PROM, which gives you a 5-month survival benefit. And, it just means it's simple. It's maybe, for some places, it may be a one-time investment or something significant. I feel that, this should be mandatory for every cancer center that treats cancer patients to use a PROM-based app or a PREM-based app, because we are here for our patients and we need to know what their experience is, what their patient-reported outcome measures are. And you have the evidence that it leads to a survival benefit. But, nobody pushes for these things. Survivorship care, we have more and more patients in India as well we are curing. because we are driving the screening programs, patients are being diagnosed early. I think that dynamic still has to change in central India and Northeast India, where access is a big issue. But I mean, there are groups which are working diligently, including National Cancer Grid and Tata Trusts and various other organizations. So this Can Survive app actually does help support cancer survivors by providing essential long-term care tools. Now, when I was in UK, every single patient who completed their treatment was given a recovery package. And as part of that, EHNA, it is called Electronic Holistic Needs Assessment, before they go back was very, very important. And this is something in health and wellness. Weight-bearing exercises, 30 minutes a day was prescribed. And I think this is something which we must educate patients that it actually leads to decreased risk of recurrence and survival benefit. And there is enough evidence to show this. And these are the apps which can actually track patients, remind them, and when they come for their 3-monthly visit, we can assess, how much time they have spent. Are they gaining weight? We know that patients who gain weight during survivorship care, the risk of recurrence is very high. So all of these are measures which will help us improve the outcome and survival for our patients. The clinical trial matching is great. I think I've already spoken about it. This is something which is the real need. And you have this Apple research kit. I'm not sure how much it applies to India, but I would love to hear if there is an app which will help us in India to match patients to clinical trials all across India. Looking at the emerging trends, I think we've already done this, and we will touch base on this later. Potential uses, of course, you will all know about medical imaging. There are a lot of apps. There is this Grok app. I'll talk about another one, pathology, precision oncology, and drug discovery. If we look at medical imaging, there is this Mirai app, which is developed by these MIT, CSAIL, and Jameel clinical scientists. It does predict cancer risk from mammogram. In fact, we are planning to start a clinical trial because we have a mammography van, and which can do up to 25 to 30 mammograms in a day when we go for a camp, which has like almost 200 to 250 women who come. It's very difficult for our radiologists to keep up with everything. But so I think this will not get rid of radiologists, but this will actually help the radiologists because the volume of care, the volume of scans that we have is quite high. So this is something which needs to be adopted for our country as soon as possible. Pathology, I think, is fantastic. I wish a lot of things like Key 67 and other things are automated with digital pathology through various algorithms, because reproducibility of a lot of tests, like the Key 67 is a simple example, is in question. And I know TMC Kolkata was working with one of the IITs to see if it worked, but it hasn't happened and hasn't come to the clinic yet. But of course, you have Lumia, CX Bladder, which looks at non-invasive genomic urine tests to surveil for bladder cancer. You have Prima Lab, and you have Clio Breast, which looks at tumor biomarkers. But again, this has not been prospectively validated. It's important to make sure that whatever tool you use is prospectively validated. Precision oncology, I think I just messaged Dr. Nikesh about, we run a molecular MDT every week, usually on Fridays. Somehow this month it's happened once. We have global experts from all the big cancer centers in the world and India join in. It's pan-India, and we usually have on a Friday about 30 to 70 people who join in, and they bring in various molecular reports. And again, it's like swimming in mud to try and make sense of it. For some of the reports, if we have an AI-based algorithm which is prospectively validated along with the clinical decision making, when we published in JGO last year that the report, which is AI generated, whatever treatment it recommends, the clinicians disagreed with 50% of them. So that is huge. So it's important that, the clinician and the AI-based recommendations are married in for the best of the patient. Of course, drug discovery, it's great. You have this deep learning, DeepMind, which is a subsidiary of Google, and they're looking at new targets. And I hope we are doing work in India, but I'm not familiar with that. So the key opportunities, just the last few slides, is I think by digital, I would say digital health, digital oncology, you engage the patients better, early detection, better compliance, better outcomes. I have shown you that it leads to an overall survival benefit. So the patients live longer. That is the whole point of us doing what we do. And I feel by this, especially for me, the excitement is in telehealth and telegenetics. As a country, we are very short of geneticists. So for me, in Chhattisgarh, to have a geneticist I have access to in US, in London, in Delhi, Hyderabad, and they provide, most of the patients are below poverty line, so they give their time out of goodness of their heart. It democratizes care, the telegenetics. But I think we need to have a formal module how to do that. Of course, it is cost effective and will help us generate real world evidence. We mustn't forget the challenges. I work in a state which has highest levels of poverty and illiteracy. So there's a huge digital divide. So not all patients have access to technology. When I go and do a camp in Bastar area, there is no internet access. So, all of these are challenges that we as a nation need to look at. Health literacy is a big issue. Even in UK, the average age when we were giving the information sheets for clinical trials was that of a 10-year-old. I don't know what the data is about India. Data privacy, data security, and of course, when we try to start a new thing, there is this, clinician hesitancy, especially some of us who are senior. And so it's very important that, with proper training, we look into that. I've already talked about the other issues. Of course, reimbursement remains an issue. And I think I will let Dr. Nikesh, you take over now. Thank you, guys. Thank you. So these are the last few slides. Okay, the poll, I think the highest, so I voted for symptom and medication management is early diagnosis and screening, 52%. Personalized treatment plans, 21%. And I think all of them are important. Clinical trial matching, we are not there in India yet, so it's 4%. Probably one of us voted for it. So if we go through the what is most important, I'll just read up, and Dr. Nikesh, you can take over then, or Dr. Swapna. We work in AI, Noor, Isofi, in medical imaging. We've seen a requirement of AI for yes, in radiation oncology. And in fact, there was a trial in prostate cancer, which was led by, I think, TMH and Ajay Agarwal from King's College. And I think for us, that will really democratize radiation oncology care. And again, wearable technology and remote monitoring, yes, I think that is really, really important. And I'm just trying to see how we do that for cancer. Will the representations be made available? I mean, this presentation, I'm sure, yes, you can have access to it, of course. Biggest bottleneck for oncology digital adoption is very practical onco EMR and cost. So I think yes, but I'm very grateful to Quetta Foundation and of course NCG for helping us. We are a not-for-profit organization. I think you should get in touch with them. If you are an organization, I'll let Nikesh talk about this, but again, there is a lot of support available in the country. Webinar recording will be noted at CG, and an added challenge is to find a way to integrate all this into something that is easy to use, used by primary care providers. Camps have low yields and only late patients do it. So I would disagree with that, only late patients. In camp, actually, when we go, I'll tell you, we went to Narayanpur. It's in the heart of Bastar. We saw 230 patients. We probably had 12 cancers. Now only 4 have turned up here. The challenge is getting them here. And I think as a country, we need to engage with the frontline workers, which is the Ayush doctors, Mitanin, Asha, Anganwadi workers. We have to create a system for engagement and education with them. So we went there so the patients may come up. And the challenges is to travel, transportation, living in a big city. I mean, they're not going to travel to places like Tata Hospital. They're not coming to BALCO Medical Center, which is like a 7 hours drive. So even though we promise free stay, free food, free investigations with the help of Indian Cancer Society, treatment under the PMJ Ayushman scheme. So we have a lot of challenges that we need to work on. And camps have high yields if you work on it. And the way we work on it is by engaging the Asha and Anganwadi workers. So they do the work for a month before we turn up for the camp. So, we make sure that our team's time is not wasted. Histopath, I think AI is very, very important. I'm currently trying to get digital pathology here as we open up more spokes. So, if somebody puts up a slide, let's say in Jharsuguda, in the interiors of Odisha, our pathologist here or somebody sitting in a center of excellence should be able to, give them the ER report, which is basic for treating breast cancer. In Chennai, about 4 hours drive out, I went to a medical college. They were not doing ER testing in this day and age, which is really sad. So ER is like costs nothing, literally. It's a basic right for a breast cancer patient to have ER testing done, the estrogen receptor testing. So I think AI is very, very important, but it's very expensive. The whole equipment is like almost 1.5 crore. So, where do we get the funding for? How do we, and then training of the people where you have to have the spoke and all of that. These are key challenges that we as a country need to brainstorm. And if we really want to make a wider reach, the government really needs to put funds in. Because I think, Nikesh, right now it's happening because of generous donations from Mr. Quetta, the Quetta Foundation and the NCG and all that.
Yeah, I think there is funding now available. So we should be able to solve the financing issue. But yes, that certainly becomes an important component of this in terms of how we do this at scale, right? And then the cost also comes down. But thank you very much, Dr. Bhavna, for running through. Before we go to the next speaker, I just thought I'll share one slide with you that when you can see my screen.
Yeah, we can.
Is the slide visible?
Yes, yes.
Yes.
So
yes.
Geetu from our team had shared this article. This was published in the British Medical Journal for Oncology in January, I think, this year. And I felt that it was a nice representation of where AI can be used, right? So if you look at the top, they are all sort of the functional areas, right? From radiology imaging to pathology to patient triage and so on and so forth. And then on the y-axis, you see the detection, prediction, and skill development, right? So very quickly, if you just uh, go from left to right, that when you talk about cancer detection, and we've talked about from an imaging standpoint, I think there are a lot of use cases even today where cancer screening can be done just through images, and they are better in many ways than the human eye to catch those things. Radiogenomics is something that is evolving. Pathology, there's a lot of role histopath included in terms of uh, how do we take those slides, like Dr. Bhavna was saying, where the expertise may not be available. Can technology at least do the first pass at that and even identify some that may have to be looked at more carefully? Um, can we triage patients who are at high risk of mortality through technology, because then they may need more aggressive treatment. Radiation oncology, I think somebody put that in the chat box as well on segmentation. And there is work that's already happening in this space. I was talking to Dr. Indranil at Tata Medical Center, Kolkata. They've already developed something that is already working well. It will probably be available for use within the next 2 or 3 months. Genomic driven oncology, I think we talk a lot about multi-omics these days. I think that space is also evolving very quickly in terms of the biomarkers and detecting early mutations. And even in surgery, for planning your surgery better, the anatomy segmentation, and even training, AI is very helpful. So in many of these cases, we always talk about AI replacing doctors. In many of these are all complementary to what the doctor is already doing, right? But yes, we do have to reimagine the operating model itself. Similarly, on the prediction side, uh, can you actually, based on the tumor progression, predict the treatment response through radiology, uh, so that know where to intervene and how much. Similarly, on patient triage, can you predict survival and also predict when somebody might need a hospital admission, so that you can prevent that. In radiation, can you de-escalate the treatment based on specific identifiers? Uh, and then there is systemic therapy benefit, drug screening, even drug development from a genomic standpoint, where AI is being used. And then for surgery, how do you find optimal margins, right? So that the outcome of the surgery is really better, and then managing complications and discharge planning. And then some skill development is also there across the board. So I just thought I'll quickly run you through. Happy to share the article. I'll just put the link on the chat box for those of you who want to review it. But I do think that I don't think it is a if anymore, right? I think we know that AI is here to stay, and a lot of applications will come up. The question is, how do we integrate them into our practice, which will require some level of reimagination as far as how healthcare delivery is structured, right? Otherwise, we'll struggle. The product will be good, and yet we are not able to make the best use of that. So I think reimagining that and our role as doctors in that is also going to be very critical. Which, as we all know, change management is hard. So we will see how that evolves. But very actively, like I said, at the NCG level, also we are trying to evaluate what are some interesting solutions that, at least for the broader ecosystem, like Dr. Bhavna was saying, taking the diversity of our country and where the most needs are, how do we target some of those areas first, and bring those to the NCG ecosystem. So with that, Swapna, can I turn it back to you to introduce Dr. Hitesh and
Absolutely, absolutely. Thank you so much. Thank you so much, Dr. Nikesh. Thank you so much, Dr. Bhavna, for your insights and thoughts, and for highlighting how technology, rather, how AI/ML is enhancing cancer care. So I'd like to now invite Dr. Hitesh Singhvi as our next speaker today. Dr. Sanghvi is the head and neck cancer surgeon at Fortis Hospital, Mumbai. He'll be speaking about how CDSS as a solution can assist doctors in creating personalized treatment plans. Following Dr. Singhvi, we would also like to welcome representatives from ONCOSure, a clinical decision support platform, who will be presenting a case study on the practical application of a CDSS solution in clinical systems, clinical settings. So over to you, Dr. Hitesh.
So good morning, everybody. This is Dr. Hitesh, and Dr. Sapna and Dr. Nikesh, thank you very much for giving the opportunity to speak on the prestigious platform NCG. I would just like to take a few minutes on talking about the clinical decision-making platforms. Now, clinical decision-making platforms, they provide evidence-informed therapeutic options to cancer-treating clinicians. Now, oncologists and oncologists around the world, they have this daunting task of keeping up with rapidly evolving developments in oncology. There are 4 million citations in PubMed related to cancer, and there are over 280,000 published articles in only 2023 itself. So there's a lot of information to be consumed. Which information is clinically applicable, which information is needs to be filtered, is there for us to know. And with this, there is increase in incidence of cancer all around the world, including our country. But there is no synchronous increase in the number of oncologists practicing oncologists worldwide, and therefore there is discrepancy in the incidence of cancer and the oncologist treating worldwide. Therefore, the oncologist needs to be deburdened. Now, when you want to deburden the oncologist, you need to have certain tools to be added to such clinical decision-making platforms. The most important is to incorporate standard guidelines like NCCN, like EBM in this clinical decision-making, so that oncologists are given options on real-world data. This clinical decision-making platforms needs to have analytics, that is, especially in cost-constrained settings in India, the cost of drugs, the cost of care, and cost of billings worldwide, that will also help the clinician in managing such patients. The clinical decision-making platform needs to be updated, needs to collect, organize real-world data from variety of legitimate resources on through AI. Such CDP, that is clinical decision-making platforms, needs to have an integrated statistic. Such tools needs to have integrated statistics. Even as an oncologist, we are able to add data to the EMR. But then what happens to that data is it lies in the memory card or in the server. It is not further converted into priceful outcomes like survival, and therefore majority of the data are lying in the computers and not converted into a publication, which can be an added benefit if such statistics are integrated in CDP. And also the added advantage is that these CDPs can have follow-ups, the reminders going to the patient. We know that in India there is 7 months delay in treating these oncology or head and neck cancer patients. So follow-up reminders going through these EMR or CDP platforms can help reminding the patient that they needs to be followed up. And the problems which we faced in CDP, or what are the challenges which we have in CDP, is this CDPs or clinical decision-making platforms needs to be validated by comparing the oncologist only group versus oncologist supported group. We are here not to replace the oncologist, but to support the oncologist to treat more and more patients. So a study was published in 2021 in Journal of American Information Association, which has compared similar kind of stratification, where an oncologist group was compared with oncologists supported with clinical decision making. Such clinical decision making platforms were supported with NCCN guidelines. And about 70 to 80% of these patients, there were 313 patients in that study. 70% of these therapeutic options given by oncologists supported with CDP platforms were identical or acceptable for alternative treatment plans. The problem with such studies was that stage 4 cancers demonstrated the lowest sensitivity and specificity. Therefore, CDP or clinical decision-making platforms should be exposed to real-world data that will help validation of such platforms across various stratifications. Thus, CDP can aid cancer treating clinicians, provide therapeutic options with generally consistent recommendation globally. It can also help reach standard protocols to the most remote center, especially in resource content settings like India. Thank you. I hand over to Dr. Nikesh for further proceedings.
Yeah, thank you, Dr. Hitesh. Swapna, do we turn it over to Nikhil?
Yes. Nikhil from ONCOSure, I would request you to take on with the presentation.
And I think this is a real case study, right, Nikhil, that you're going to present about how a clinical decision support solution is actually being implemented in a real setting.
So first of all, thank you so much, Dr. Nikesh, Dr. Sanghvi, and thank you so much for NCG for giving a platform to showcase how OncoSure can benefit oncologists and how it can be used for clinical decision support. So instead of talking about the features, what we decided is we want to go through it in a case study manner, where I would be presenting a case study that was done on OncoSure and how that case study was implemented, how that case was implemented. So we are going to, before I start, there is a very interesting poll that has been put up, which would try to understand the different challenges faced by oncologists in general. So I would request everyone to please go through the poll. That would give us very good insights on what exactly are the pressing concerns and issues for oncologists today. So let me start with a case study. So we are talking about a patient who is a 52 years old male. The first consultation was done, and the dates are, of course, the patient name is not the PHI is protected. The dates are also modified here. So the patient did the first consultation was on the 1st of December with the complaints of non-healing ulcers. They have trouble moving the tongue, pain with swallowing, and unexplained weight loss. So ONCOSure then allows the doctors to create the medical history of the patient, right? So for this particular patient, we have the comorbidities that were reported were overweight and obesity, ocular hypertension. There were no allergies reported. Now, this information is very, very critical to be captured in a systemic manner so that this information can be used for determination of further course of treatment. So based on this information, ONCOSure suggested certain workups that needs to be done. Now, we do not have the cancer staging done at this particular stage. So there are multiple options that are presented to an oncologist. History and physical examination, biopsy, chest with CT. Now, only 6 options are being shown here, but there are multiple options if you scroll down here. Oncologist, and each option has its own protocols. Each option can be customized based on oncologist's preferences. So whether you are doing a history and physical examination, or you are doing a procedure like you are doing a surgery, or you're doing lab tests, you are doing a radiology diagnostic procedure, everything has its own protocols, everything has its own parameters which can be customized based on the requirements. In this case here, we have history and physical examination that was done. We have a biopsy that was done, and we also have chest CT that was done. So when the reports came in, the reports were fed into ONCOSure, and ONCOSure captured that a biopsy confirmed that it was a malignant neoplasm of anterior floor of mouth, and the TNM staging was T3N0M0. ONCOSure automatically captures that information, feeds it into the medical history column, and this information then again would be used for further treatments. Just to mention, the first part where workup was shown, it also includes different treatment options, including the biomarkers. So if there are any biomarker requirements that needs to happen, and Dr. Bhavna has mentioned that the ER is a basic requirement for breast surgery, and that has not happened. ONCOSure would tell what are the different things that needs to be done, including the biomarker treatments as well. So based on the clinical diagnosis, ONCOSure suggested following options. So surgery was the preferred option, but clinical trials was also one of the options here. And I do agree with the speakers here that clinical trials, and Dr. Bhavna has mentioned that earlier, clinical trials does not have a proper platform in India, and we do not have a centralized registry where clinical trials can be seen. But ONCOSure would love to partner with companies who actually can create these platforms, and we can integrate them in ONCOSure platform, where if there are any clinical trials that are happening, and if the patient is eligible for the clinical trial, we can show these options here so that the patient can get registered in the clinical trials. Depending on upon the consultation with the patient, the oncologist decided that we want to go with the resection of primary and ipsilateral or bilateral neck dissection. Now, another thing that ONCOSure does is it not only suggests the treatment options, but it also allows you to automatically schedule these treatments. One of the problems with Dr. Hitesh mentioned was the follow-ups and the information that is being flown to the patient, right? So if the treatments are scheduled, many of the times the patients do not come for the treatments because they are not provided with timely reminders on their treatment options here. So ONCOSure has solved that problem by integrating various communication platforms like WhatsApp, where once a treatment gets scheduled for that particular patient, whether it's a surgical treatment or it's a chemotherapy treatment, reminders would be automatically sent to the patients so that there are chances that the patient would actually come and get the treatment done, and the dropout level would be as low as possible. So once the surgery happened, ONCOSure allows them to add different surgical outcomes. So here it was adverse pathologic features, and based on that, it was decided that we would go for an adjuvant treatment. Now there are multiple options which ONCOSure would suggest for adjuvant treatments. Now all these options are based on NCCN guidelines. The protocols are already pre-created for all the treatment options, for the chemotherapy options. However, customization is available, and we would see how the customization happens on ONCOSure. The decisions that were to be made is we have multiple treatments where we can give an RT, or we can consider a systemic therapy and RT combination, out of which some of the treatments do have RT integrated into their protocol, but some of the treatments like weekly cisplatin did not have an RT integrated into their into their protocols. So what are the different options, or what are the different parameters that a doctor can see on ONCOSure to make that treatment decision? First of all, every regimen has its own regimen category. So whether it's a category 1, category 2, category 2A, category 2B, and these are the categories which are prescribed by NCCN. So you very well know how the treatment works. It also presents an evidence block. Evidence block again has multiple parameters associated with that. So what is the affordability of the treatment? What is the consistency, quality of the treatment? What is the safety of the treatment? What is the efficacy of the treatment? There are many times, even though the treatment is recommended, but there could be financial constraints that the patient may not be able to go for that particular treatment. There could be chances that the treatment option, even though it's a best treatment option, but the treatment itself is not available in the area. So the protocols do have all the details on what kind of treatments you can go with. Once you have decided that this is the treatment that you want to go with, the protocols, as I said, are inbuilt. But a doctor can actually go ahead and customize that protocol. So in this case, your weekly cisplatin radiation therapy, the doctor did not go for a radiation therapy. They went for a weekly cisplatin chemotherapy regimen. Now, weekly cisplatin already has a protocol inbuilt. The doctor can then decide what kind of pre or post medications needs to be given for this particular treatment, whether pre-hydration or post-hydrations are required, whether the medications need to be given before the treatment starts. So all these things are automated in ONCOSure. You can simply create your own protocols. You can customize these protocols, and these protocols are now available for you to use every single time a decision is to be made at that particular instance. So once the protocol is being decided and the treatment is scheduled, ONCOSure automatically schedules the treatments. Now, these treatments are scheduled date-wise. So ONCOSure, basically, when I mentioned that ONCOSure sends weekly reminders or timely reminders to the patients, so that is how we do that. So we have a treatment calendar for the patient where the treatments are scheduled on particular days. Now, we also have a little bit of intelligence built into the background where these treatments can be scheduled according to the departments. But as the treatment date approaches, the messaging platforms would keep on reminding the patients about the treatments that they need to go through. The doctors and the nurses would also have an option to add the details for the treatments. What happened to that particular instance when the treatment was given? Whether there are any adverse events that have been reported. We can also update the reports of all these treatments. Now, ONCOSure has built-in AI to read certain kind of reports and extract the data out of it. But since we want to democratize this platform, so we also have an option. We can also partner with multiple AI companies. For example, somebody was talking about radiation, the counter for the radiation oncology. So it would be easy for us to integrate those treatment options, those solutions here. So if somebody is, let's say, specialized in breast cancer treatment or radiation therapy for breast cancer treatment, so we can integrate those options here, and then we can utilize those platforms to give accurate treatment options to the oncologist with ONCOSure. Again, we also have something called as smart workflows, which can automatically create your orders, which can automatically create your prescriptions. And then obviously, once the treatments have been completed, the reports can be added here. The AI is applied on the reports to read the reports automatically, to add the details to the medical history, and to allow the oncologist to use this information to create a proper care plan for the patient. So that's what I wanted to focus. But one of the things which I would like to mention here is why ONCOSure does what it does, because its platform is based on standards. So we use SNOMED CT terminology servers. If anybody's aware of what SNOMED CTs are, that is one of the largest terminologies that are used in the world, and it has a lot of options. So ONCOSure has an inbuilt platform where we can not only use standard SNOMED CTs, but we can also create these SNOMED CTs. Now, what happens is, because of that, every single thing that you see on ONCOSure has a code that is associated with that. This makes it very, very easy for us to integrate into your EMRs. So if you have an EMR which supports SNOMED CTs, or even if you don't have an EMR which supports SNOMED CT, but want to use ONCOSure's SNOMED CT platform, we have APIs which can be exposed and given to your EMR so that they can easily incorporate SNOMED CTs into their everyday workflows. Because of this, the flow of information between OncoSure and other technology platforms is very, very easy. And that's how we make sure that the information that is being collected and used is always kosher. It has the sanctity that is required to process any AI algorithms that we need to process on this platform, on this data here. So I would like to just stop here and see if you have any questions on that. By the way, we do have the results of the poll. There is a very close tie-up between patient volume and time constraints and complexity of treatment planning. So these are the top two problems or challenges which oncologists face, and OncoSure can definitely help out in mitigating these challenges for you. Thank you so much.
Thank you, Nikhil. There is a question from Dr. Girish about what is the cost and how do you integrate with the existing EMRs? We can stop sharing the
Right.
screen.
So
I can just.
yeah. So let me answer the second question first. How do we integrate with the platforms? Now, that is a very, very important question because we have so many platforms, and it's important for platforms to talk to each other. And that's where OncoSure's methodology of using standard-based protocols and standard-based treatment options come into picture. So everything that you see here is standards. We use FHIR protocols for communication. We use NOMAD CTs. We use ICDs, CPDs. So every single option that you input here has a code associated with that. Now, as I said earlier, it's easy for us to integrate with any EMR or any platform which uses the standards. But even if they are not doing that, our inbuilt APIs and SNOMED City servers would allow them to integrate very easily this solution into them, and in fact, making them also a completely standard-based platforms. So that was the part of this. That was the answer to your second part of the question. Now, coming back to the first part of the question, the pricing depends on what kind of settings we're talking about. So we have plans where even if a single oncologist with a single clinic wants to utilize this, it would be very, very cost beneficial for them as well. Obviously, the pricing model differs from, let's say, a single oncologist to a 100-bed hospital, 200-bed hospital, 500-bed hospital. So the pricing model is defined in such a way that even a single oncologist would not have any burden on the pockets while utilizing this platform. And if you have any if you need any more details about that, if you can send me the details of your organization, I would be in a better position to give you what the pricing model we are suggesting for it.
Dr. Rohan has a question. In fact, I was also going to ask that. Is OncoSure a rules-based engine or is it a AI-based LLM platform?
It's a great question. So it's a combination of both. It is a rules-based engine. So while present in the treatments, it depends on NCCN guidelines, but it's a guideline agnostic. So we can have any guidelines integrated into that. But at the same time, it uses the information which is being inputted into the system to and we apply AI algorithms on the top of that to give better treatment to give idea of better treatment outcomes and the treatment efficacy to the doctor, so that they can make an informed decision while they are prescribing a particular treatment. So it's a combination of both.
So it is bringing in information from other, meaning language models and outside of the information that is already provided in terms of bringing some. Okay. And I think is a follow-up question, is this being positioned as a CDCSO class A medical device, or is it a decision-making aid that presumes liability rests with the doctor on choosing this as the only decision-making aid?
So it's a very, very good question. It's a decision-making aid because there is no way, what we believe is there is no way that we can replace oncologists. It's just not possible. A human oncologist has better understanding of the scenarios. There are a lot of things which AI does not take into consideration. There are emotional factors which AI does not take into consideration. So this platform, even though it gives you all the options, but it also allows you to customize those options based on your requirements. So it is not a class A device. It is a clinical decision-making tool which has been given to the oncologist to make decisions based on their own customized factors.
Okay. Other questions from the group? I know we are almost about at time. Nikhil, thank you very much for taking us through the solution. And I think in general, clinical decision support is an important area. I know it's a fairly broad topic depending on how you define the scope of clinical decision support, but even from an NCG perspective, we are starting to think about uh, uh, having a platform that can embed our standard guidelines in terms of the NCG guidelines, then that can be available to everyone again as a
Correct.
choice. And especially in lower resource settings where that level of expertise may not be available, at least this can become a good handy reference at the point of care.
Dr.
Two
just-
other, I think Dr.
Dr.
Naresh has his hand. Yeah.
Allow me, I just want to add one point here, which is a very interesting point, which many of the audiences would understand. So the biggest benefit of having a clinical decision support is not just about customizing your protocols, but also making sure that you customize and standardize your protocol. So it's possible that an oncologist might be visiting multiple centers which are in rural areas. It's not possible for the patient to every single time come and talk to an oncologist in the main city. So what ONCOSure can do is it can customize your protocols, and it can make sure that those protocols are followed in multiple treatment areas that you visit. So I think that is one of the biggest case studies that we are working on right now, and we are actually getting very good responses to that.
And Dr. Girish is asking if there are any legal issues.
I'm not sure. I mean, if you want, we can go in specifics on what legal issues that you're talking about.
Yeah.
So if you can send me your questions, I would be more than happy to get on a call with you to answer your queries with respect to the legal issues. I would like to understand what exactly are you referring to as legal issues.
You can just put your contact details, Nikhil, in the chat box where Dr. Rohan wanted to get that. So it'll be easy for
Yes,
everyone.
yes, absolutely. So I'm going to put my contact details
Okay.
on the chat box here. Give me one sec.
I think Dr. Girish was clarifying that legal issue if we don't use the treatment suggested by the platform. I don't think so, Dr. Girish, in the sense that the way it is set up, it is more of a recommendation. I don't think that it is necessarily structured right now, at least in a way that there's legal liability. But yeah, we can certainly look into that.
So
Okay.
can I share my screen for a moment, because I have my contact details on that screen. So if anybody wants, they can just simply copy it from there.
Either way is fine. Either way is fine.
Okay. So I'll give me just one moment. These are our contact details. And we can also share the presentation with the team. Swapna, if that is okay with you, we can share.
I
this
think we'll
presentation.
upload the webinar, Nikhil. We don't separately share the presentation, but anyway, it will be available. Okay, with that, we'll bring this to a close. Once again, thank you all for joining on a Saturday morning. And again, if you have other topics that you are interested in, our intent of doing these webinars is to really bring things that we are looking at on a day-to-day basis and find interesting to this group. But we also want to make sure that it's a good use of your time. So if you have any suggestions or ideas, especially if there are solutions that any of you are using in your current setting, whether it's a hospital or outpatient clinic, that would be the ideal thing to profile, because those are actively being used in a clinical setting. So if you have ideas or suggestions, you can just send it to I think Shraddha had put her note ea@ncg. I'll put it again. At this email address, and no, we will consider that. Thank you very much. Have a good rest of the day.